Well, welcome, folks. Welcome to the Stop LAPD Spying Coalition's the webinar part 8, our Power Not Paranoia series that we started back in on March 31st. Um, and it's been really good to see a whole bunch of folks joining in, building together. The reason why we started this series was that every Tuesday the coalition has a scheduled in-person meeting, and as a result, with the disruption that is happening in everybody's lives, with this crisis, this health crisis that we are seeing, it was necessary for us to stay connected. It was also necessary for us to keep on building that power, because it's during these times that the police state expands, the surveillance power expands, the police power expand. So how are we talking with each other, to each other, building together? Most of the time, a lot of our meetings are working meetings as well, but this is also an opportunity to invite folks who bring in different perspectives from their own fields as well. So today, the way we wanted to look at it was that, just we had invited, and we're still trying to hope to see if Dorothy Roberts is going to be joining us. They are back in the East Coast, and they had said that they'll be joining us on the webinar. But today we were going to talk about the police state, race, and public health, and just sort of like really dig in deep as to what we are hearing out there. A lot of us have never heard of things like immunity passports or contact tracing or serological testing, and all of this vocabulary is pretty new for a lot of us folks. Also, we know that a lot of these things that we have known, historically speaking, how public health has always been a key element, a key part of the police state, a key tool of the police state to trace and track and monitor people. How public health has been central to how white supremacy has continued building, and how different bodies have been subjected to various forms of experimentation and a lot of other stuff that has happened. Today there was 3 articles in the LA Times, and that'll maybe get us going and that get the conversation started. And one was about the serological testing, and it was about the antibody testing. And there's a whole industry that has emerged out of that. There was this article was talking about that it's costing people anywhere from 165 to almost $270. And places like body sculpting shops and people who are dealing in Botox and various other things are offering these tests to people. And it was a detailed piece that how people are being ripped off, and even being offered these certificates of immunity as well. So it's really, I mean, there's a whole sort of various, I don't know whether the economies of scale is the right word, but there's a whole subset of these industries that are developing too. There was also this really intense article about people being invited in the South for some testing, and how folks are having a Tuskegee moment about that how for 40 years bodies were subjected and lied to and completely denied any access to healthcare, but yet at the same time how the intent to cause harm was very central to how people were being harmed. And then there was another article about surveillance. While the article didn't really go too deep, it basically hovered around the surface around invasion of privacy. But we know that it's much bigger than that. It's really the intentionality of the police state to cause harm. So with that backdrop, we're gonna get started with our conversation. And today, like I said, we had invited folks both from the academy and also who are on the front lines of organizing. But the way we're going to do this is that because in order to protect the space and the sanctity of the space, there's been a lot of Zoom bombing that is going on. Out of the 8 or the 7 webinars that we've had previously, we've only had one instance for about 4 or 5 seconds where somebody sort of like tried to disrupt it. So what we are doing, what we have done is, so what we do is usually that's why you all have been muted. We, of course, we're fighting the police state. We're abolitionists, so in a way, we're kind of policing this space as well. But it's out of a lot of love, out of a lot of respect for a lot of folks, and the respect for the space. So please, the chat room is open. If you want to make a comment, if you have a question, feel free to ask, and we'll definitely unmute you. And also, there's a function there where you can raise your hand and put it on the screen, and we'll get to that too. And if you're on the phone, and if you don't have access to a computer, you can always text us with your comment or question. And the phone number to text is 562-230-4578. 562-230-4578. So with that, we're gonna dial right in, and some of these questions we had already sent to Dorothy, but apparently there may be some technological problems going on. So who we have today with us is Bita Imani, who's a professor, who's an epidemiologist and a professor at Charles Drew, and also co-chair of the COVID task force at UCLA for race and equity. We also have Jamie Garcia, who is a registered nurse, but also a frontline organizer for Stop LAPD Spying Coalition. And then I'm going to also ask Harry Gilbert, who would just give us a quick update, because we're also looking to release a bulletin on every 2 weeks on giving a state of the community health on a regular basis as well. But just a couple of housekeeping things, that if there's anybody who is with the media or a reporter, please, before you publish or do a story or anything, just talk to us before you quote anybody's comments and everything else, because we want to make this to be a very free space, so people can speak freely, people can open up, people can exchange ideas. So please do let us know. And if you're a cop, well, we don't want you here. So that's just basic housekeeping that we have. So let's just Bita, let's just get into it. You've done a lot of research. You've had a lot of experience as an epidemiologist. And so how does race figure into the broader public health arena? Let's just, on a very baseline level, let's start this conversation with that.
Well, okay. Well, first off, can you hear me? Okay, yes, I switched to this one. I want to just, thank Stop LAPD Spying again for this opportunity to be able to be here and to be building this conversation over the last couple of weeks. We've definitely, I'm speaking on behalf of myself, and I'm sure for Harry, Mina, and Jen, we've been so grateful to be able to think through these things with you guys. So we appreciate the partnership and the opportunity to really kind of bring what we've been calling like the public health perspective, right, to this conversation. And so right now, for you to open up asking the question about race, for so many of us, racism is actually central to this entire thing. Anything that's done in the name of safety, whether it's public health safety as well, is a conversation about security. Therefore, it becomes a conversation about race, right? In particular, whose lives should be protected and from whom. And I think being able to talk about it that transparently, right, and get to the core of it in this way is something that we appreciate that we've been able to do together. So getting to your, thinking about it more and thinking about why, Dorothy Roberts' voice and scholarship here is so important, is that if we can think about race as being a political system, right, as being something that's governing people and sorting them and putting them into categories, then we can see how this entire COVID conversation is a conversation about race. It's about who has the opportunity to get to have access to the things that we're saying people should be doing, right? And then it's also about the ways that, like, centuries-long racism, whether we're talking about settler colonialism, whether we're talking about racial capitalism, whether we're talking about the war on drugs, the war on crime, the war on terror, right? The ways that they have made some major structural vulnerabilities that then make something like COVID and its kind of collateral consequences unevenly distributed. So at its core, this is a racial conversation. The war against the virus, it was one of which we never should have accepted, right? In this context of white supremacy to begin with, in this context of racial capitalism, set with colonial and imperial logics, the war against the virus will always be about safety and security frameworks that are going to reconstitute themselves in more fascist ways that consolidate power, that innovate to continue to dominate land, people, and markets. We've accepted that this is a biomedical conversation also, in addition to accepting the fact that we're going to try to go protect the economic health. And then accepting this is a biomedical conversation, we also now go back to the origins of kind of racial theory, and that there are biological differences between us. And because there are biological differences between us, therefore we need the state to come in and to manage us. So yeah, I mean, I hope that, I could kind of give a little bit of, in terms of how race is operating here.
Thank you. So building on the same point, Jamie, how do you see that taking place? How do you see race race figuring in your work as a frontline care provider, as a registered nurse at a hospital, and so I know from an organizing point of view, we've had a lot of conversations around that. But you are in a very vulnerable population, just the communities that you serve. So talk about it, like, what is your observation and what is from your own vantage point about race and public health and health service delivery?
Well, I'm going to pivot a little bit from that, Hamid, because I think one of the things that that as like building on what Bita was saying, is that I wanted to pivot a little bit into testing. And this is one of the things that we're starting to see, this latest craze that you were speaking about as far as immunological testing, meaning that people are, curious as to if they've had the virus, the COVID-19, if they've had COVID-19 without knowing, without having, intense symptoms. And I've been in spaces where people are kind of driven by just curiosity, like, oh, I had a cold, in December, maybe that's what it was, or, I had some muscle aches, maybe I had it already, or, and this race to kind of find out if they've been exposed. And I think one of the things that in working with our public health team right now and kind of understanding the dangers, right? The dangers of giving over your DNA to the state. What happens, already in the world of surveillance, and how different components of our lives are already automatically picked up, from automatic license plate readers, closed circuit television, facial recognition technology, all these different ways. Important right now as we start realizing that immunological testing is another form of surveillance, and kind of this one form of surveillance that's being driven by fear, right? Because most people want to know if they've had the virus or not. What is the insidious thing around this is that the narratives that will start to be built once we find out, that possibly there's been a wide range of folks that have been infected already, right? And when we see, what will come from this data, because now this data is increasing, and the FDA has allowed a certain amount of tests to go forward without even verifying if they are accurate or not, is that if we do come to find out that more people have actually experienced the virus, this will start to essentially dismiss and hide and erase the experience of the Black and Indigenous communities, and who are being affected by COVID-19 mostly, right? We've heard stories coming out of New Mexico where Indigenous populations, communities there, are being gravely impacted. That's my home, where my family is from. We are hearing about the Black community being impacted. And so as we kind of race towards this to find out, my concern is that this erasure of who needs help, who needs the basic infrastructure and the public health services to actually do what they need to do, which is stay at home, have clean running water, have food access, and actually have financial support to be able to maintain those things. So I, so that kind of is like the trickling down effects of this race to find out if or not you had it. And there's several things even behind that, because we don't know if even having had the virus will give you any kind of protection. There is no hard science behind that, right? So this is now another money-making opportunity for these biological companies, biotech companies, to create products that people will pay. And in this LA Times article, they were saying folks were paying anywhere from $150 to $300 to get tested. So we don't even know if your antibodies will protect you. We don't even know if these tests are actually accurate, if this is just another way for them to get money from you. But then we risk the fact that we're going to erase the impact of this virus, right? And when we erase that impact, what we're erasing is truly what's going on. And it's the fact that there's communities that have been in a public health crisis since the beginning, right? Black and Indigenous communities have for centuries had to deal with job insecurity, housing insecurity, food insecurity, water insecurity. And so that is my biggest concern being on the front line, is because I see this continually in the healthcare field, is that there is this, and I think that for anybody who's experienced being in a hospital, there is this erasure of a problem, right? It's the non-compliant patient. It's the patient that has, these multiple diabetic issues, cardiac issues, because they don't care about their health, right? So there's this kind of like continuation of the erasure of the fact that this is about public health, this holistic sense of public health, of what people have always needed to stay healthy, that now their lives depend on it to stay healthy. And so this, I see this troubling kind of trend of continually erasing these issues. And now with immunological testing, folks don't even know why they're doing it, and kind of are now slowly learning that it's inaccurate, and we don't even know if it's going to protect us, but what it's really going to do is erase again.
Mm-hmm, mm-hmm, mm-hmm.
I want to add something here to
Sure,
Jamie's point about erasure that I think really comes back to your opening question about centering race and racism, right, to this conversation. Obviously, by now people have had some exposure to the overwhelming health disparities, both in people who are becoming confirmed cases for it, or in people who are dying disproportionately from it. In some cities, you have all the people who are dying from it being Black persons. Here in Los Angeles County, you have overwhelming deaths amongst people who are Native Hawaiian or Pacific Islanders. and other areas, it's Latinx, Latino, Latina deaths. So you see these really dramatic situations where you can't exactly erase that, right? Like you have to deal with the fact that, okay, COVID is not affecting everybody evenly. It's getting at the core of white supremacy. It's rooted in deep histories of anti-Blackness in this country. It's rooted in deep histories of, only thinking about, communities of color life in the ways that it can be some sort of problem, right, to white life, right, white property or white ideas. So there's both this erasure, and then there's also this almost hyper visibility. And I think one of the tensions that we have, thinking about Jamie kind of going through the complicatedness of testing or not testing, is that we are also, as public health people who consider ourselves progressive or anti-racist, we're also taking that data and saying look at this huge problem, but then the solutions then that we're pushing for are solutions that are right back into that biomedical model of we don't want disparities in testing. We want access to the testing, right? If you're going to be, opening up the economy, then you have to consider us for contact tracing. Even with that argument, we're a little skeptical because we're wait a minute, there's this whole thing called policing and surveillance, and we just said it's a public health problem, right? So it's, it's really become this conversation where things are both erased, invisible, and also hyper visible. But still, like, the core of it remains completely off limits when it comes to talking about or somehow disrupting.
So what obviously is, and again, I want to just ask folks if they have any comments or questions, please put them in the group chat, and we'd be happy to. And if you want to make a comment, please either push that raise your hand or just put it in the chat room, and we'll be happy to unmute you. Shakir Perman is also the co-host. If I miss it, then they'll see that too. And if you're on the phone, just please feel free to text or comment or question at 562-230-4578. 562-230-4578. So what obviously what I'm hearing is, and correct me if I'm wrong, that of course race, which is fundamentally a political category, but has been reformed or recreated as a biological category. So I want to go there, but I see that there's a comment here that they say, I'm concerned about the way race is being recognized. So maybe we'll just just go to Angela and see what Angela, just would love to hear your comment. So go ahead.
Okay, now I have to work the technology.
No, hang on. You muted yourself. So now go ahead and unmute. Hit unmute. No, unmute yourself, Angela. There you go.
Okay, I'm unmuted.
Yes.
Hi, everybody. Yeah, I'm really concerned with the way that race is being discussed. I think early on, many of us have been pretty consistent about putting forth an understanding of racial differences as something that emanates from social structural positioning. But I think that that in particular, there's a kind of way in which race becomes reified, that that we begin to slip in our discussions, even talk about people as being different biologically, and concern around that. And so even I've heard those kinds of comments even in progressive circles, and I'm real concerned about that.
So Angela, let me go ahead. Bita, did you have a comment?
Yeah, I think, that's right on. It's right on. And I think the public health discourse right now of, we're having so many wars converge into each other. We have so many racisms that have built into each other that right now this war on virus, like, there's something around what is race and what's racial and how things get racialized that's being redefined. But because public health, and specifically a public health surveillance, thinks that it's more enlightened because it's saying, we're not talking about bodies, we're talking about the virus, right? It's only, like these last couple of weeks with all its eugenics conversations that are, underlying all this stuff, it's almost as if we're back to this modernity, this moment of saying, hey, no, we have these science conversations, and these science conversations are completely divorced from these histories of racism, right? And we need to just talk about the biology. When we have had no liberation, right? When we have had, very little consciousness around race, even both in terms of how, what its usefulness is and what a system of racism is, right? That now we're all of a sudden going to like kind of embrace this idea that we do have different biologies and that somehow we need to have checkpoints and passports to kind of differentiate between us. So I think that you're absolutely right. In fact, the way that race is being talked about right now without talking about it, but we think we're talking about it because we're talking about Black and brown bodies and we're talking about structural inequality, is very concerning. So
let me just go back to Angela. I'm sorry, just now since you opened it up, so I'm gonna just hit you up again. But so you may have to unmute yourself. Talk about so this is an opportunity now, in a way, to have not just in a way. This is an opportunity to have this conversation that how a construct has now, over time, has been turned into this biological construct, And then again, we have an opportunity that how deep there's our programming around racial science, that we continue to reconfigure race rather than and I think beat up the last time we were talking about it, saying rather than abandoning it, we continue to come back to it, right?
Come back to it, we police it. I mean,
right.
Just when we look, when I saw the pictures of the differences in the way that Black communities were policed around social distancing and those in white communities in New York. That's an example of this kind of the way that race is deployed in this way. And I just, it's horrifying. It is an opportunity, but it's not always an easy one, because, we kind of, it's very easy to slip into the language of race ourselves. And that's kind of, part of my concern.
Right. So how would you, so what is our, like, in a sense, like, since we're at it, like, so from your vantage point, what is our call to action in this particular moment?
Is to focus on communities rather than raced bodies, to focus on vulnerabilities rather than raced bodies, and to be super vigilant, I think, about our languaging around those issues. Like, we have to, as we talk about these communities, talk about the structural conditions that underlie these differences in every single conversation. I think that's, I think that's key. And I also think it is important, and it is an opportunity, as we've seen in the news, to just highlight the way the response follows the logic. I think it's interesting, though, the way that this has had this bizarre unintended consequence, perhaps for some whites, who then feel themselves invulnerable and flock to the beach and feel like, okay, now that we have this news, we're okay to be around each other and blowing each other's face. Of course, that becomes a public health risk to the rest of us. Their presumption of their own invulnerability. So, I don't have the answers, but I'm real curious to see us grapple with that. And yeah, for me, when I saw the difference in policing in New York, it was specifically, I interpreted that as emanating out of the different ways in which the racialization discourse has been understood. And another opportunity to do what is typically done.
And I think, and just building on that a little bit, just from being and working in hospital settings and being and working with multiple patients, and I work in Boyle Heights, so I predominantly deal with a Latinx, Latina population. It's always, baffling to me how doctors themselves will all of a sudden be baffled, because they will say simple things like, well, I don't understand why they don't take their medication. Well, I don't understand, or, Latinos, they always have diabetes, hypertension. They never take care of their feet. This is just common in this community. That's just how this community is, where the conversations around infrastructure, and when, in the hospital that I'm at, imagine, and the community is not a wealthy community, and it takes probably about a good 15-minute bus ride to get to the closest grocery store, right? And so now we're talking about, they come in with fancy paperwork saying, okay, this is what a diabetic diet is. This is what you need. This is what you should be doing. Your 3 meals a day, your snacks in between. And, and they're not even taking in the context that people, can't even get to the grocery store, and getting to the grocery store takes about an hour and a half, takes a fortune, because now they have to bring kids. If they bring kids in tow with them, everybody has to carry the groceries, bring them back home. Now we've got to meal prep. Now we've got to, but at the same time, maybe I work 2 jobs, maybe I work midday, maybe I work all night. How do I organize my diabetic medication if I'm working at night? And so the whole social structure that's going on around there is not even considered in the education. And this is even like, mostly Latinx folks giving instruction to other Latinx folks. And so they're completely erasing the social kind of conditions that are happening currently right there in their face. And so I see that kind of persistently, even in the context of folks who, like have access to, or to being able to have access to addiction counseling, to have drug intervention. It's like a kind of expectation that people cannot get better, that this is a choice, that it's not a disease, and that it also has, you know, ramifications that are political and social as to why people have migrated into the United States, that have certain traumas that make folks susceptible to wanting to use certain substances to allow them to cope with trauma while they are trying to live, while they're trying to survive under poverty. And that's one of the biggest things when I was watching the Senate hearing today, that there was no discussion. One senator mentioned, maybe this would be easier if everybody had access to health care. That was the only breath that was spoken in regards to any kind of social structure, social political structures that are impacting how people are experiencing this pandemic right now. And it's absolutely frustrating to work amongst people who are supposedly educated, supposedly, you know, have spent hundreds of thousands of dollars in an education, but cannot bring that analysis into their practice to understand what people actually need to get better. But then it becomes a racialized experience. And it's absolutely frustrating. And so understanding that that existed prior to a pandemic makes you realize just how it becomes even more exacerbated. So, I mean, honestly, for everybody who did watch the Senate hearing today, it's all about opening up the economy. It has nothing to do with restructuring how society is right now, giving us what we need to, you know, be able to do what we need to do. It's completely about who are we going to sacrifice so that our economy doesn't tank.
Mm-hmm. So we in this time of COVID, so what we're seeing is, so in a sense, this categorization and reconfiguring of race that is happening. So Peter, I'm going to go to you with that where the conversation that is emerging, of course, because of the immense impact on the Black community and also indigenous communities as well. I mean, there are these reports that the Navajo Nation, if that was a state, it was like the third state in a sense of being impacted as a result of COVID-19. And of course, we know, I mean, the histories of that, the complete intentional lack of, and it's not just happenstance that there are no resources, it was intentionally created like that. You know, around healthy food, around immediate access to resources. So what are we looking at that, how do you see or foresee public health and the conversation around public health, reconfiguring it under these, where now this whole thing about susceptibility, about vulnerability, about, like, you know, predisposition, that certain bodies are predisposed, and again, the racial category is very much in our face. So how do you see that emerging? And I see your hand, Angela, as well. I'll go to you. Let me just go to Bita, but let me just, so Bita, talk about that as a public health expert, as an academic, as an epidemiologist.
I mean, I think for, you know, many of us who think that we have to study the social in order to understand what's happening to the disease, right? Like, so specifically being a social epidemiologist, you know, when you were describing what's going on in Native communities and indigenous communities here, and specifically, you know, with the Navajo Nation, when you have 1 in 5 persons there who are diabetic, right? That doesn't just clue you into, okay, they might be vulnerable to getting COVID, and you know, they might be vulnerable to having a severe case of COVID and possibly dying from it. That should clue you into, like, what has been happening, that 1 in 5 persons there has diabetes. And so that, you know, like, on the one hand, we're having this conversation to be like, look at, like, you know, the years of structural inequality, because it's making people more at risk here. And we keep saying, you know, we're not talking about biological risk. We're talking about a social risk. Specifically, white supremacy has put them at risk. And because white supremacy has put them at risk and has, you know, now this disease is here, and so they're in danger of this bad outcome, we still are here talking about COVID. Mm-hmm. And talking about COVID is not going to get us to talking about white supremacy. And so, because of this, we have so many different conversations on race and racism that are happening. Getting back to your point earlier, Angela, about like, you don't like the way race is being talked about. It's also that how many different ways is it being talked about and being used here? And then also that in the arguments that we're making for some sort of racial equality or racial equity, or so some recognition that institutional racism has been at play, we still then are coming back to the virus, right? Saying that we need testing, you need to make sure you include us when it comes to vaccines, right? But then, and what are we seeing if we bring up the example of the policing and what's happening in New York, right? Or all across the nation, that gap, that racial gap, so that targeting, that surveillance of Black and brown bodies, right? Whatever gains we might have thought we had more recently up till now, whether it was to decarceration or putting more pressure on the idea of policing and accountability, whatever any of that was, that under COVID, is it back, have we, what have we actually gone back to, right? In terms of that gap. I think around the issue of race and the virus, there's so many different ways we can talk about it. And one of the other things that I want to definitely add here is that, from the perspective of somebody who is a social epidemiologist, we're talking about war, and we're talking about a perpetual and a continual war, because even if, for example, we were to find out tomorrow that the police are not doing any sort of like physical harm, right? There's all the data that shows that simply by having policing in the communities, you have increased anxiety, depression, right? PTSD, all these other layers. So that, and the reason why I bring this up, and I believe it's relevant here, is that if we then look at like what we're calling like the extremes of the COVID conversation, right? The most conservative or the most progressive, even our most progressive doesn't acknowledge the fact that we are under war, that we are in war, and that we are being having a war waged against us, which is part of the reason why they still keep going back to the same discourses and accepting the same frameworks in order to try to advocate for something for us that would somehow substantially change the set of conditions that we're in. We come to this right now through the task force, or as people who are, very much concerned with public health, with the idea that these are the tools that we have. We are a bunch of ideas, and we are a bunch of tools. And as critical as we want to be about how we are thinking about race and deploying them, we are still putting these tools in the hands of those that we know that have given us great reasons not to trust them, right? And even amongst us who we would say would be the most progressive and representing us, we still don't think they get it the way that we're talking about it, for them to be now using these tools to somehow prevent this disease, right? And to do all this other work. And I bring this up here specifically, once again, reminding us that we are a bunch of tools, to say that you cannot come to us and ask us, what should we do? Because really all we have to offer you are our tools. Does that make sense? It being completely, kind of forthright about it.
Yeah. Angela?
Yeah, I was just going to add, I've done a bit of work in the Navajo Nation, and one of the things that, in addition to the extremely high rates of diabetes, just the access to food is challenging, and so Jamie talked a little bit about that in the context of our communities here in Los Angeles. But when I say, there's no food, there are no stores within a mile, within a few miles, there are no delivery services. I mean, when you break down what it means to be protective in our lives, in our, Instacart worlds, where you can just spend the extra $5 or $6 easily, and only just recently did they open up food stamps so that you could access those delivery services with food stamps. So those are just a few examples of how, just the way that, it's not the Navajo Nation as race, it's the condition of the Navajo Nation, vis-a-vis a whole range of things relating to health. And so just the specific examples is what I was thinking about. I also just, there are so many questions that I have that I don't hear being interrogated. Like even the racial differences with Blacks, one of the things that I hear about the differences with regards to deaths. And I also hear stories of people having to go numerous times before they're finally diagnosed. And so I'm actually wondering whether some of these differences in deaths might not be because, as we see in other areas of healthcare, the concerns of Black folks about their bodies, about their health, about their illness, about their feelings of dis-ease are rarely taken seriously. And so, I haven't heard whether the difference we see in deaths are similar in the testing. I haven't seen that, and I haven't seen anybody interrogate that at all. Maybe they are, but I haven't seen it.
Jamie,
I was just going to say, like, just from the front lines and just the experience of being a nurse and understanding these dynamics, it's one of the kind of things that I go in as almost a mode of saying, anytime I have a patient who is Black, I immediately do a deep dive into the chart. I immediately have to be sure that what I am doing is very clinically on point, because the excuses start happening. And I'm only just trying to talk about what happens on the front line and what talks about trying to do the best job as a nurse as possible, because I already assume that the stories start, and they start in report. Oh, they're pain seeking. Oh, they're complaining. Oh, they don't, and it's like a they, as if they start becoming a category, right? And then, but then at the same time, and this is just something by nature that I do, is that I have to acknowledge that racism is there immediately, so that I can do the deep dive into the chart, so I can do the deep dive into the care, and that I can push back and say what needs to be done. Because there are countless times that I have had a patient where I've had to intervene, and I've had to say, no, this is not being handled correctly. And I can get into the argument with the doctor about the issue of race, but what I need to do is just get into the issue of what's clinically being presented and what the person needs and what needs to be pushed. And so I think it's important as a frontline healthcare provider that we are more vocal about this being a reality, because it's when we try to hide it or we try to act like it's not happening that these kinds of situations just continue to perpetuate themselves, continue to happen, and aren't realized in as a reality, as a nurse, and having to call each other out. And that happens, and it's very uncomfortable. But I want to say that it is a fact. But there are those of us who understand that and realize that we have to fight more when we are delivering care. And I just have to say that I just wanted to say that, because it's a kind of a reality that makes me nauseated, that has to happen, and that an intervention has to be done like that to just get the appropriate care a person needs.
Well, Jamie, just to honor you, there's a comment here that I want to publicly thank you, Jamie. Jamie has battled on behalf of my own family members, nurse, anti-racism warrior. So just as a way to, and it's an honor to have you as a comrade, as an anti-racist warrior for the coalition. So Jamie, so how do you, while we are at it, how do you navigate the structure? What is your MO? And you don't have to, like, of course, it's I don't want to get personal here, but just because since we are at it, and I think we can all learn from, because these are also call to action, these webinars. So talk about that.
Well, it's one of those situations where I don't go to work to make friends, and I don't have many friends. And I say that in the sense that
you can say that about the police commission as well when you go there.
Yeah, but I say that in the reality that there's a lot of chumminess that happens, and that's what I consider to be grooming, is that people are grooming you to be comfortable with poor care, with negligence, with cover this up for me, and that chumminess And when I see that happening right away between a person, whether it's a doctor, whether it's nurse to nurse, whether it's assistant to assistant, that's where my alarms come up. And I say, okay, this person isn't here to do the job. This person is here to be friends, right? And it's not that I don't want camaraderie, because we all need camaraderie, but I need to first know clinically what you're about. You know, clinically, are you there to do your job? The second piece that I think that alerts me and makes me also realize what kind of conversations and what kind of way I'm going to interact with someone is the low-key comments. You know, like as a student nurse, it was very odd to me that, and I think we all have to realize anti-Blackness within our own people, but there was a Filipina nurse that, and it was very odd that she didn't associate me to being a Latina at that time, but she said, yeah, everybody that's from this community, they're all drug addicts anyways. And I stopped for a minute because I was so surprised that the comment was coming directly to my face, and I knew exactly who they were talking about as far as a racial category, but it's so prevalent. And a lot of times, just to survive, because the day-to-day job of a nurse is that you have 12 hours, you get a 30-minute break, and the rest of the time you're racing against the clock. So I don't have time to get into it with people, but I have time to identify them and mark them. And the one time I did get into a conversation was I did see one of my colleagues, and she was having a conversation with a stomach specialist, as I would say. And he was commenting, and he was commenting with another doctor who was a Latino doctor, and they were discussing the issue at the border, the concentration camps at the border, and the children. And they were very loudly talking about how they didn't deserve toothbrushes, they didn't deserve toothpaste, that they needed to be sent back, that they were costing too much money. And she was, from a very, almost very, from her heart, just sympathizing with the situation, not even having a political analysis, that at a certain point, the conversation, I had to stop the entire unit and I had to intervene. And I had to say, you are wrong, you are not right. And what was so interesting about how deeply ingrained patriarchy is in the medical field is that all they did, instead of argue with me, because I started talking about, you know, foreign policies, I started talking about wars, I started talking about structures, that the only thing that was being said to me, because mind you, I am a nurse and they are physicians, right? So that whole dynamic is there, that classism is there already. All they kept saying to me was, no, 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 no. Literally, those only words rolling from their mouth. And at one point I had to say, you know, no isn't an answer, and it doesn't make what you're saying right. So those realities really exist, and to navigate them at work is that you don't make friends, you look out for the small comments, and you protect the people you treat. And that's the only way to survive in the medical field.
Thank you. Harry, you have your hand up. You got a comment or a question?
I wanted to contribute a little bit to this like question of care that like Jamie has so well explained, but also like embodies a kind of, you know, relational and like militant care, like militating against like anti-Black racism, patriarchy in the workplace. Like what we really, things that we need to be concerned about are when surveillance parades around as care as well. And one thing that I wanted to bring into the conversation was how a lot of times these kinds of surveillance infrastructures often coincide and use public health infrastructures and vice versa. And that's very rapidly happening in this time in which care starts to look like surveillance care and carceral care. So thinking about even like categories of at risk, like we hear that in terms of neighborhoods that are quote unquote high crime, and what do they need? They need more surveillance, they need more policing. Like neighborhoods or communities that are quote unquote at risk, what do they need? More surveillance and honestly, more policing in that kind of imagination. And oftentimes what we're seeing is that a lot of these programs for sentinel surveillance that are being recommended, or syndromic surveillance or serological surveillance that is targeted towards communities, are taking as a given what it means to be at risk or have high comorbidities. And what that means is that surveillance infrastructures are instituted where, you know, surveillance is already happening in those communities in which it's already happening. And in fact, it's relying on a lot of war on terror infrastructure, surveillance infrastructure that was created post 9/11. And so we see all of these coincidences and sharing between different components in this algorithmic ecology, or these different kinds of like layers of surveillance. And so I think one thing that, you know, we need to constantly be thinking about is the state will oftentimes say that it is caring for us, but what does that actually look like in terms of how that care looks? And oftentimes right now it's looking like extending and expanding different kinds of anti-Black, anti-war on terror, anti-Muslim, anti-Indigenous settler logics, surveillance logics, in order to quote unquote produce care. Yeah.
Thank you, Harry. So folks, we're gonna continue with a couple more questions and open it up in about 5 or 10 minutes maybe. So if folks have any questions or comments, please post them on the group chat in here, and or just raise your hand, like, and then if you are on the phone, so go ahead and text us with a comment or a question at 562-230-4578, 562-230-4578. I mean, you know, there's a lot we can talk about. I mean, I think, of course, one of the immediate thing, as we are talking about race and racism and white supremacy, you know, the whole notion of American exceptionalism and how it plays out, and that whole machismo and patriarchy playing out, images of you know, just a whole bunch of white folks in Huntington Beach, and, you know, just pushing back and with their guns walking into the state house in Michigan and all of that. So so I think there's much to unpack here, but, you know, of course, you know, for these conversations will continue on a weekly basis. But let's move into the area of surveillance a little bit, and because that's, of course, the Stop LAPD Spying Coalition is one of the key works that we do. I'm gonna just Beta, Jamie, talk about these notions of, or these things like immunity passports. Like what is an immunity passport, and what does it mean, and why should we have one or not? So Beta, Jamie. Beta,
Well,
you want to?
I'm just gonna talk really quick about something that happened, and I'm gonna pass it to Beta, but just to kind of give an example of how divided the scientific community is. How divided the scientific community is, and how much we don't know, but you know, scientists claim to want to know, is that the WHO, the World Health Organization, about a week or 2 weeks ago, put out via Twitter clear messaging saying, do not, you know, believe in immunity passports. Do not think that this is something that you can do. This, you know, we discourage this completely because there is no hard evidence that immunity is even something that can occur if you've contracted COVID. And about an hour later, they were completely assaulted by 3 other scientists, and I didn't take their name down, but I just watched this drama unfold in front of me, where they were forced to take down those different warning signs that they did, and they were forced to explain how, okay, we didn't want to scare everybody. Maybe immunity is a possibility, but we don't know yet. So the whole notion of being against immunity passports, the World Health Organization was forced to take back that claim and say, and it was the science community that was basically saying, no, you cannot tell people that that's not going to be a possibility. You can tell people that we don't know yet if, you know, you can be immune, but you cannot warn against that. And so, which led me to believe wow, they really, really want to establish this category. And it makes you wonder if it's going to be kind of like a fabricated category, even if people, even if, say, there is a vaccine or there is some type of moderate immunity that you get to the COVID virus after having contracted it. It made me realize that there is a definite desire for the creation of this category, because they wanted to leave that possibility on the table. They wanted to be sure that nobody was taking that possibility off the table.
So Beta, for some of us who don't know exactly what an immunity, can you just give us like what exactly is an immunity passport and what is?
Well, I mean, I think that still remains to be seen what exactly an immunity passport will become. But the idea would be that it is some sort of documentation and based on testing, serologic testing, right? Most likely looking to see if there are or not the presence of, certain antibodies, but also as a companion to also your vaccine history, right? Because I think that there's also conversations about what the immunity passport would look like after a vaccine, were to be developed. But I think for the purposes of how it then pushes us to like rethink what's going on in this moment is that in order for there to be an immunity passport, that means that there's going to be some sort of border, that there's going to be some sort of checkpoint, right? That there is like that people's movement is somehow going to be regulated. And then if we, once again, because surveillance is a conversation about race, then it means that who are we saying needs to be protected from whom, right? Because, on the one hand, we're, Harry did a wonderful job of, drawing our attention again to the fact that, okay, this contact tracing, this economic health, right? The pushing the people to go back, to work, and then wanting to protect some people's economies, right? Because it's not as if, like, when we talk about economic health, we're not just talking about the economic health of those who are extremely privileged or powerful. We're also talking about the mass unemployment rate, right? The mass number of people that are like moving into like, poverty, right? So that, but when we think about an immunity passport, we have to then think about whose life, whose land, whose property, whose ideas are we trying to protect in this context? And I think that, once again, trying to be, the public health ally of sorts, right? Or in solidarity, like with movement from the position of being somebody in public health. What I'm saying is that the COVID conversation, the conversation about serologic testing or antibodies and these things is distracting us from being able to see what is happening here in terms of the ways, for example, like if we were to just think about the question, how is the health system being reorganized right now in this time of COVID that works to the benefit of the interests of the health system versus the interests of the patients? Already in the conversation between Angela and Jamie, we're talking about healthcare disparities. The fact that we know people can come to a system, both of them have the same amount of disease, and one of them might leave without their leg. Right? And what does racism have to do with that, right? How does that happen, right? And so, thinking, when we think, I feel as if the immunity passport conversation, the contact tracing contact tracing conversation, all this stuff that's pushing us to look at the biomedical is really distancing us from understanding what's happening in the social and the political, which is why, going back to like, kind of one of the hearts of the conversation tonight, and wanting to bring specifically Dorothy Roberts because of her particular take on how race is a political intervention, is to remind us that here in public health, as we are rewriting what is race in the context of COVID, actively doing that, right? What political project are we serving? And then the converse to that being, because public health is a set of tools, right, and frameworks, if we were to somehow take a hold of that, how are we going to then protect our own people's health? Because COVID is a real thing, right? Like people are dying, right? And this is concerning to us. And we want to prevent death, and we want to promote health, and we want to treat people who are sick more, just as importantly, because somehow that's gotten lost in all this, right? We want to do treatment, but what's the political project that we are wanting to use these tools for? So, I hope answer the question.
Yeah, no, thank you. So Jamie, before I go to Harry, to give us an update, like on the what is the state of the community health and what are things going on around the reopening and all of those conversations. Put on your organizer hat, Stop LAPD Spying Coalition, and somebody who is just sort of like mapped out the stalker state and the architectures of surveillance and everything else. So with all this conversation in play, how do you see the stalker state operating, particularly with centering public health and how information is going to be moving?
Well, I think one example I can give that actually our folks that have been, looking at and we're working and we're able to dismantle Predpol. I think Predpol offers a really interesting example of the expansion of surveillance, and we are actually going to be releasing just a Medium post tomorrow in regards to what Predpol is planning. For folks who don't know what Predpol is, it's a technology that essentially uses an algorithm to crunch crime data to create boxes where they predict 500 by 500 square foot boxes where they predict crime will happen, right? And then police are instructed to go to these boxes and to police those boxes by driving through the area. And driving through the area creates a kind of deterrence to, deter criminals from committing crimes. And I say that all in quotations, right? So what Predpol has just about 2 weeks ago announced is that they want to work in conjunction with public health workers, right? They want to aid in helping to maintain and to be sure that people are self-quarantining if they are positive, and they want to assure that if stay-away orders are given to a certain area, that people are staying away from those areas. So Predpol is under the assumption that they are going to be able to access public health data. So you test positive, right? This information goes into the information sharing environment, which is one of the reasons why I kind of throw this caution out about, getting serologically tested for just because you want to, like you're throwing your data out there. And when we think about the stalker state, there are so many ways now that we are forced to give over data. So in a sense, right? So you go and you find out whether you're positive or negative. This data goes into the public health system. We know already that they are expanding this kind of infrastructure that's monitoring not only syndromic surveillance, which is like, our hospitals picking up more people with symptoms and these different ways that they're surveilling, but this data is going out, right? And we know in the coalition that once data is kind of in the environment or been picked up by somebody, because of issues that now become national security, threats or can be deemed national security threats, the accessibility to that data is very easy, right? So, and Bita's been talking about this war on the virus. We've been hearing about them combating the virus, right? Casualties of wars, frontline workers, right? All this terminology. That's to get us comfortable with us, seeing COVID-19 as a national security threat, right? So, as in the deeming it like a national security threat, right? Law enforcement can get access to data, or data is able to be easily exchanged, right? So going back to Predpol now wants to be able to use that data and not to run it through the algorithm, but to say, oh, just give us all this public healthcare data and we'll put it on one of our maps, right? They're not even trying to do anything fancy. They're just gonna put it on the map. And what we'll do is we'll identify where these hotspots are of people who have been actually contracted the virus, and we'll patrol those areas to ensure that they stay in their houses. We'll patrol the areas that have stay away orders to ensure that people, right? And so now they're marketing themselves as this aid, this tool that can aid in doing this. And so we, of course, are coming out and exposing this. But this is not the only techno solutionism that's out there, right? This technology as being the answer to everything. We see this in the GPS tracking devices that they want to be able to use, where now you can actually the safest thing to do now is to be sure that you turn off your Bluetooth when you're out in public, because you can unknowingly actually be pinged by someone else's phone if they have the app that is tracking where they're going. And if your Bluetooth is on, they will know that they've been in contact with you. And if you end up turning positive and that information goes to public health will, in a sense, alerts all these apps as to where this person, is positive. So you don't even have to have downloaded the app to all of a sudden become subjected to this type of tracking and surveillance. Wow. So what we have to do is really start looking out to see how these tech companies that are, into surveilling our movements are now trying to profit off this pandemic as well, in the name of safety, in the name of aiding, in the name of trying to deal with this pandemic, which are really just fortifying a surveillance system that that is probably so delighted to now have access to more public health data and to be able to legitimize itself in the middle of a pandemic and normalize itself so that people actually start giving into it because of fear, because there is a desire for a resolution and for that resolution to come as fast as possible.
Wow. So, Anja, did you have a comment?
Yeah, well, it's not a comment, it's a question, because I may have missed a couple of our Tuesdays. That's been one of my concerns as the state moves towards indiscriminate testing, and we see that on Skid Row, where they're just set up and they're trying to just test everybody, asymptomatic testing. Where do we stand on that? How are we moving ahead of or pace with that? Because the serological is a little easier because it seems like it's kind of snake oil, but testing for the virus itself, and we know about the asymptomatic transmission. Where do we stand with the expansion of testing and the continued sharing of data?
Absolutely. I mean, well, of course, for the coalition, we absolutely reject and oppose that, because it's also a matter of not just collecting data, but what happens with the data as well. So, as the conversation around data abolition and what does that really mean. But I think at this stage for us, we're also monitoring how how this is expanding and what are the various things. So we're in that, it's almost like in that flux right now, that as things are emerging. So that's why, so maybe, so this is the time to go to Harry to kind of give us an update as to what, because to your point, there's definitely, the apps have already been launched in certain places in Australia and Singapore and various other places. And I think the first day in Australia, about 1.2 or 2 million people downloaded the app. And then another million people till people started realizing what else is at play as well. So it's here. I mean, it's very much, in the Google and Apple and everybody else. But I think earlier to Jamie's point, I mean, it is such a classic 9/11 moment as well, because there's a feeding frenzy on CDC dollars. It's just like the DHS, Homeland Security dollars happened after 9/11, and billions and billions of dollars were open for profit making. So now there's a feeding frenzy going on. So everybody's getting into the game. And it's almost like, I see James Kilgore is also on there too. These things are going to turn into like ankle monitors. People who've been doing electronic monitoring work, that everything is like, we're almost like everybody becomes an ankle monitor. So let me go to Harry. And Harry, just before we open it up for other people's comments, can you give us a quick snapshot of where things are right now? And I know there was a document. Let me just open it up. So which you were working on, and it's in partnership with the coalition. And folks, this bulletin is going to be released by Thursday. So, and we plan to do like every 2 weeks release a bulletin. So can you walk through this briefly, Harry?
Yeah, absolutely. So, it's hard to keep up with all of the news that's being produced, and this is, a document that we put together, and, want to share it with everyone to have bi-weekly, to have grounds on which to engage a rapidly shifting reality. And So, I mean, I bolded in red what I want to just like briefly go over today, which is that Governor Newsom had announced, or well, it was announced that LA County with all certainty would keep stay-at-home orders in place for the next 3 months. However, it was also announced by Governor Newsom that it would be likely that California would move into stage 3 of reopening. And as ever, we need to remember that this is always reopening the economy to higher risk workplaces that necessitate closer proximity between people, and that would occur within about a month's time. California, Governor Newsom is also, if you scroll down a little bit, looking to build an army of contact tracers of at least 10,000 people. And a lot of this will be done by hand, but the state has a pilot program with UCSF, UC San Francisco, and a software company, Dimagi, which is working on some algorithmic computational tools to do this kind of like care and reporting and tracking work.
And isn't Dimagi deep into the CIA and some of the more broader national security or the international intelligence agencies and all?
Yeah, I know someone on a previous call had opened me up to that. I know that they have relationships with organizations like Accenture, which and tight ones, like a lot of their staff is from Accenture, and they have, you know, sordid history both of leaking data, but also having pretty liberal policies with keeping data and information in circulation in order to, you know, generate profits and revenues. Apple and Google plan to announce release to public health agencies their app by mid-May, but it's already out for kind of beta testing for public health agencies as of April 30th. Some other key points are that
you want me to scroll down, or?
Yeah, if you just scroll down to the syndromic surveillance section. Sorry, I haven't been. There's been a few projects, apps that have been launched that seem important and are a part of what we've been talking about tonight. So there's this launch of this app called COVID Near You, which is a syndromic surveillance project app that users can participate in. And it actually, the article explains, it actually pulls data that was made available to public health workers, but started to be collected post 9/11 and is a part of anti-terror surveillance programs. And also that there are novel kind of like laboratory testing that is being sold to companies to do return to work protocol testing. So companies can determine what workers can and cannot, quote unquote, return to their workplace. And then if you scroll down a little bit more, the last one is the immunity passports, actually lower than that I just want to highlight. And we've talked about this a little bit, is that, you know, the WHO has corrected itself to say that there's not enough evidence to show that immunity passports would, quote unquote, do what they're intended to do. However, there's already a huge startup market for immunity passports. And there's this article in Business Insider that highlights all of these different companies and startups that are getting capital investment in order to generate immunity passports, in order to enforce them. Yeah, so lots of different news items that I think reinforce and also are examples of things we've already been talking about tonight, but are, you know, different pieces of different parts of the infrastructure that is coming together in this moment and is really like remaking what, you know, healthcare looks like and what policing and surveillance looks like.
Right. Thank you, Harry. That was super helpful. So with that, now we're gonna open it up, and so if folks, we're gonna try something. We're gonna unmute everybody, and hopefully, you know, but of course, just with the caution that if things go out of control, we'll have to mute everybody. So we just, because we want to have a collective conversation, we want to hear what people are thinking. So let me just quickly see this one comment. It's from AJ that while I invite them, these are always such difficult conversations for me. The statistician in me knows what we do with data and how unstable and unsafe it is for the communities from which I descend. However, as a health interventionist, I rely on technology to provide healing practices to my people. So what infrastructure of innovation must we engage to also combat state and corporate sanctioned surveillance? I mean, that is a very key question. So let's just so let's see if folks want to talk about this question. And here I just hit unmute. If people can mute themselves, if you're not going to be talking, please just do us a big favor and go ahead and mute yourself. Thank you, much appreciated. So yeah. So you know, AJ raises a very key question. I mean, like, you know, so how, anybody wants to address that? Anybody wants to talk about it?
I mean, we were having this conversation the other day, and I think it also gets to the core of what maybe Angela was asking around what's our position with testing right now, especially in the context of Skid Row, do we expand it or not? You know, there has been histories of imperial science, medicine, right? Histories of how we do and how we practice medicine, who practices it, all these things that lead us to a place where these are the tools that we have. And I think at this moment, because we are having a fundamental, like we are having such a conversation about health and medicine, we have to be more thoughtful in what we expect those of us who are coming from that field, right? What we expect us to do, given that these are the tools, one, that we've been trained on, two, that we have in our hands right now, and three, we don't necessarily have the space to try something else out, right? And, you know, and also, I mean, this gets back to what we were saying about what does a decolonized public health look like right now in the time of COVID, right? Is it going to be just kind of that decolonization where we talk about theoretically, like, this is how we've come here and this is what we're doing, or is there a space for us to say, hey, like, through testing, you get some sort of information, and this information builds up people power, and in that people power, you're able to organize for a new way of like relating to each other, right? As a, you know, as a way of like having resistance. So I hear that very much in AJ's question, that, you know, if decolonization is a process that at the end, that included within it says that you're supposed to take things back, right, and shift power dynamics, right, around land, and ideas, right, and resources, then like, can public health as a tool set, in how we have it right now, can it do anything for us? Yeah.
I'm kind of thinking that, I mean, for me at least, is an obvious step for us is, you know, to absolutely oppose the policing of social distancing. I mean, we've got to kind of demand that up front. And so, you know, we hear about the Predpol stuff, and that kind of tries to embed that infrastructure over top of.
So let me open it up for other folks who are on the call. You know, just some of us have been doing a whole lot of talking. So any thoughts, any, because it's a call to action. Like, what are people thinking when we hear these things in the conversation?
Mohammed, may I say something?
Please, Pancake, please.
All right, how's everybody doing?
Good, brother.
Okay, you know, I've been studying certain patterns throughout history. But in moving forward with this pandemic, I'm looking at with the contact tracing some of our communities, people of color, the discrimination that may be evident moving forward, like application process would discriminate, housing, employment, so forth and so on. And I think we have to be really vigilant and be watchful for that. and folks, they've lost their jobs, and, and folks that have contracted the pandemic, and moving forward, how can they be, in order to be restored? And we have to really be watchful for any discriminatory practices, in the future. I'm looking at that.
Absolutely.
People of color, those that are will be penalized. That's what I'm saying. I remember the AIDS pandemic, when AIDS first came on the scene. And as far as like folks, applying for a job, or, they wouldn't want to say you got HIV, boom, 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 boom. Well, are you a threat to the other workers, and how it's going to freak? So I think we have to really look at that,
Thank
moving
you.
forward into the
Thank you. I'm going to just hit up one of our comrades who's on the call, Virginia Eubanks. And Virginia, I don't want to put you on the spot, but Virginia has been an old comrade for the Stop LAPD Spying Coalition, was really a lead and an amazing researcher who helped us develop our Data Bodies project, and has written several books. And so Virginia, I mean, your work has really been around this whole structural, well, just I'll let you talk about it. If you can briefly just kind of hit us up, like, so how do you see this information sharing around, because your last book, Automating Inequality, and the impact of information gathering. So yeah, so the stuff that you're hearing, how do you see this figuring?
First, I'm going to check. Can you hear me?
Yes.
Excellent. Hi, everybody. It's really great to see all your faces. It's been a minute, so it's really nice to be back in community with Stop LAPD Spying, and really appreciate the series so much. So thank you all to all the hard work you're doing in this time. I can really, I think, Hamid, in the most direct answer to your question is we don't know. Like, we really don't know what's going to happen with this data, and it's something we should be paying such incredibly careful attention to. And I can only really, right now, I can only really reflect on my own experience. So I live in New York, but I live in upstate New York. A little harder to get testing here than it is to get in other places, though ramping up. I myself have been struggling with a respiratory illness for the last 6 weeks, and did finally go and get drug testing just a couple of days ago. And one of the things that was really interesting about my experience is how hard it was to find information about, like, who the actors were, what their policies were, like, what's the relationship between the testing company and the New York State Department of Health, and whatever data company they're using to manage the sort of madness of the demand right now, with more than 300,000 cases in New York State. I will say one of the things that happened to me that was really interesting, you also aren't told at any point in the process it's going to cost you money, which is, I believe it's because in New York State, at least active virus testing is free, but I'll find out. I couldn't figure out before I went and actually got the test. One of the things that happened that was really interesting is that my doctor had actually given me the not quite correct phone number for the testing hotline, and I was one number off. So instead of being like 3065, it was 3064. It was still within the New York State Department of Health, but it was not quite the right number. And so I got a busy signal several times. And then, like, being a journalist, I was like, well, I wonder how long this busy signal will last. And so I just kept calling back. And eventually I got a message that said, this number is not in service. It will be recorded by Google for, like, customer service reasons. And so one of the things I'm really thinking a lot about right now is, like, what are the relationships between the state and private entities right now, and how do we make sure that they're visible? How do we make sure we know what the rules are going forward, and that we, and by we I mean our communities more broadly, have not just like a seat at the table, but like real impact on the processes of controlling what happens to our health information. Because I think clearly we're in a really difficult position where the very community that most need testing in order to make good decisions about their lives, their livelihoods, and their health are also the very same communities who should be most suspicious of the collection of their health data. So it's really a double-edged sword that we're struggling with right now. And I mean, that's why I'm on this call, is that folks like organizations like Stop LAPD Spying have been thinking about this stuff for a long time. And I really do feel like we need to continue to think these things through together. So appreciate the opportunity to be here, trying to learn.
Thank you, thank you, thank you. And I see Nadia's hand up. Nadia, you got a comment or a question?
Yes, hello. I was trying to turn my video on, but it doesn't seem to be working. But yeah, I just wanted to thank you all. Good to see people's faces and hear people's voices, and appreciate this knowledge sharing. And yes, Pancake, great to see you.
You too, Nadia, my friend.
Yeah. And so anyways, I don't know, I was just thinking of also, like, I really appreciate what folks were bringing in around the contact tracing and the immunity passport. And it just made me think of then how, like, so I'm a teacher, so I think about how then youth, right, students are constantly under criminalization, surveillance, right, from the minute they leave their home, right, and even within their home, right, on their devices, then walking to school, you know, knowing a lot of my students get harassed as well, and brutalized. So I'm just thinking then how this relates to that, right, and how these hotspots, like, right, Jamie, you're kind of bringing that in. And so then, you know, I think about then what it means, right? Obviously then more police on campus, these contact tracers, right? I believe somebody mentioned this, I think the army of contact tracers they were talking about. So what does that presence look like then in schools? And so that's something I'm thinking a lot about. And so for me, I'm like, so then how are we continuing to build that power to push back in the various ways and spaces we can, right? Whether it's as teachers or parents or mentors, siblings, medical workers. So so really then I think now is when we start really pushing or continue pushing back against the narrative specific to this and how it operates in that stalker state. So so yeah, I just wanted to throw that out there, and again really appreciate this webinar too.
So any thoughts about that? Because what I'm hearing Nadia speak to is that and this is something that the coalition is working with some really awesome folks, with Mina Sharif and Jen Alvarez and Harry Gilbert, and of course Beta as well, around, like, you know, really centering public health in stalker states. So Nadia's question is exactly to that point, that for young people going to high school, there is such a vulnerability factor that you're constantly being traced and tracked. So Jamie, let me just, let me unmute you, and go ahead and unmute yourself now. Okay, go ahead.
Okay, you know, I just wanted to add a little bit to where the expansion of, like, data gathering is going. And I'm just going to say this as a theoretical thing, but there are hospitals now that I'm very well aware of that are going into virtual hospital mode now. So not only are we seeing communities, you know, that are already kind of or that are surveilled, targeted and surveilled, data being collected, whether it's, you know, through, you know, the policing technologies that we're used to, or the data that's being collected now through basic testing for COVID-19. There is a movement now for hospitals to move into virtual hospital mode. So you'll be basically receiving hospital services at your home. And what's interesting about this is, to be eligible to do it, you have to basically have a home first. You have to have running water. There cannot be, you know, certain components of your social living situation, like active drug use. You have to be willing to not be drinking. And but the interesting thing about it is, and I was thinking about kind of like when we think about the stalker state and this kind of larger web of data collection, that when I started to really think about this kind of structure and layout, I was like, oh, this is for like rich folks, you know, who have access to all this stuff, access to someone who can care for them, or their injuries are not that bad. But as I was looking into a little bit about, you know, the Wi-Fi services, how this information is protected, because medical information is protected through different laws, I had made this comment and I was like, oh, so yeah, this information doesn't go into the Google Cloud. And I was corrected. And they're like, no, it does go into the Google Cloud. So, and I don't quite understand what all that means yet, but I was like, oh no. And so the movement is there, and predominantly it's there to deal with the surge, because now we have COVID right now, and it's not necessarily in California overwhelming hospitals, but come influenza season, which will start again in September, we're going to have units filled of people with influenza and also with COVID. So the using of this technology now is to move more people out so the hospital can maintain. But building on that, I wanted to say that when we think about data collection, and going back to AJ's point, is that again, we're moving the conversation away from infrastructurally what is needed. What is needed to maintain people's health? Because I have to say, as a healthcare worker, when I'm dealing with you, you're in an acute situation. You have an infection. You are, you know, you're sick, and I need all this data to do something immediately to get you well. But the hardest part of being a nurse is when I discharge you, because I know you're going back to the same conditions that brought you here, and I know I'm going to see you again, because what I did was preserve your life for that moment. But because the structures and the conditions you're living under have not changed, I know I will see you again. And so that's where we have to think about, as you know, healthcare workers, as scientists who are working with data, is that really, is it for long-term structural changes that will actually promote and give health, or are they for just immediate, you know, quick fixes that do not do anything to actually preserve life? And so, so I think that, you know, when we think about the kind of data that we're working with, we have to really be honest with ourselves about that. And then another way that I address that question is that that's one reason why I am an abolitionist, where I don't believe in policing or prisons, because I know inherently that police should not have any type of access or place in this kind of data if it needs to be collected. They do not belong in this situation. So if you are not actively working towards abolition, then you are kind of and bringing this conversation into those spaces, then you are becoming part of a system that's fortifying these spaces and allowing police to have access to those spaces.
Thank you, definitely. So folks, just raise your either the hand or send us a message if you want to make a comment. Virginia just posted a comment that New York State has sold a huge amount of its capacity, both for dealing with the unemployment crisis and the Department of Health, to Google. So now this is how information is now moving. And you've been hearing us speak about the stalker state. So this is basically, when we talk about the stalker state, this is what we are talking about, that how information moves within various systems and within various institutions as well. So when Jamie was talking about and Virginia is talking about giving it all to Google, well, there's a whole lot of information that Google is going to have, and how that would be used against us is anybody's guess, because it's in development. I'm going to call on you, James. I don't know if John Rafling is still on the call or not, but James Kilgore is a friend. He's a comrade. He's been doing a whole lot of work around the electronic monitoring and the ankle monitoring. That's been a major issue in our community. So James, how do you see that this thing with this COVID piece and the stalker state and the surveillance environment with already, so now we're adding multiple jeopardies to people's life and vulnerabilities, because now you're walking, it's almost reminiscent of lantern laws, like when you talk about, you know, these ankle monitors and electronic monitoring. So just very quickly, just to tell us how does that figure into this COVID-19 stalker state?
Well, I think when we're talking, you know, about immunity passports and geofencing and so forth, we're talking about devices that are really reconfiguring the urban space and have the possibility of confining certain communities, restricting movement, and gathering data. So I think for me, this is a moment where this kind of crude, almost analog ankle shackle is now becoming more and more of a surveillance state device with more and more capacity and more moving toward a cell phone. So like on Friday, I got an email from a company called Captira, which I'd never heard of before, but they're advertising a GPS app to trace people who are on pretrial release, probation, parole, blah, blah, blah. And it looked like something that was sort of like $9.95 for probation and parole and law enforcement to gather data.
Wow.
And it just made me think about the whole question of how deregulated this is. We've already seen how all these tests came onto the market that there was no kind of quality control or any sort of regulation of them. And so now we have surveillance devices that are coming on to the market, gathering data of for questionable purposes, and no doubt commodifying it, selling it, putting it on the Google Cloud, all these sorts of things. So I really think the electronic monitors are merging in with the broader, as you call it, stalker states, and becoming more and more surveillance devices as they also increase their capacity.
Mm-hmm.
And I've also seen change people who are on straight up parole. Their parole agent shows up and says, put this app on your phone. From now on, we're going to meet virtually. But once they put that app on their phone, of course, their phone is now gathering data for the state. So I think there's a lot of movements, and I really appreciate all the things that people said here in terms of trying to pull all the pieces together.
Absolutely.
Fantastic information.
Absolutely. No, I mean, it's also where sometimes, we kind of just get caught up into this 30,000 foot sort of level, like it's Apple and Google and all of that. It's really the day-to-day, the subcontractors and all of that. And so any other comments? I'm also going to unmute Jen Alvarez. And if you guys want to unmute yourself and see if you have any comments and add to the conversation, Jen and Mina. So from our side, you're unmuted. If you would like to make a comment, please go ahead and unmute yourself and add to the conversation. Both our public health folks, the students, postdoc, and all of that. So yeah. Anything, Jen or Mina, you all want to add? Okay, I'll give it a thought. So. Okay, so so here AJ has thrown another question. Thank you, AJ, for this active participation. So we're saying that, are we calling for a multi-tiered systems where, number one, we work toward abolition and healing? Number two, we put our people in these systems to monitor these technologies, okay? And number three, we create alternative pathways. What does a multi-tiered system look like? We work toward abolition and healing. Number two, we put our people in these systems to monitor these technologies. And number three, we create alternative pathways. Beta, Jamie, Jen, Mina.
I mean, I think that the number one is, absolutely, right? The number two makes me think about Nadia's question, like who's going to be on the campuses, who's going to be at the schools, because you can see already right now with like the idea of contact tracing in its most progressive forms, right? Like it either does not, there are people who are trying to put forth a contact tracing. There's no contact with law enforcement, right? But you can imagine that it might morph into a community policing type situation where you've heard people make the argument, oh, it's better if, the people who are doing, the policing come from the neighborhoods, right? If we match by race, if we match by place, if we give them an implicit bias training, if we do some cultural competency, right? So the number two is making me think about the ways that, how do we do a number two without falling into these other traps? And it's very important here with the number two in the context also of contact tracing, that we don't end up doing that, and I imagine a system where like, even if we say no law enforcement and we say, hey, let's, our teachers can also become contact tracers. Like what kind of
Right.
position does that then put, the teachers that are on these campuses? That your number, AJ, the number 2 makes me think about all that stuff together. And the number 3, in terms of creating the alternative pathways, that's something that, historically, the reason why we're able to be so what we call resilient, right, to still be in, kind of in this, like, in this revolution and process, right, is because we have made alternative pathways. But I think how we bring those alternative pathways together and put some politics around it, that's the part where, I think, either with either number 2 or 3, it's like, what are the politics? What are that are underlying these things? Those would be the things that I think we'd have to think about more.
So let's build on the alternative pathways. Jamie, any thoughts about that?
Yeah, I think about that a lot, and what it means to be a nurse in a hospital, in kind of the stuck in the box of Western medicine. But I think the conversations that I'm having more now, and that are even in this conversation that we're having today, and thinking structurally, when we think about decolonizing medicine, when we think about decolonizing these different situations that we're in, when we think about contact tracing, and just to kind of keep building off of what Bita is saying, what does it mean to take the moment that we are in, where we know that our communities are going to be impacted. We know that there is money now that's going out to organizations to actually implement contact tracing. How, in some ways, can we take hold of this opportunity to actually start to orient the conversation away from the tunnel vision of COVID and into a broader vision of what structurally is going on around people? How do we bring multiple voices into a intervention where it's not being led by like a classist system and a classist hierarchy that you see in medicine? Because in the end, it is the folks that are closest to what you would call the patient, or to an impacted person, that essentially does the work, but is often not given the option to decide what to do, to give that input. And speaking as a nurse, it's often, even though I know what needs to be done, even though I know that a certain treatment should be happening, my hands are tied unless I'm given an order, right? Because it's very militarily driven. So what opportunities do we have right now to invest and to engage, and to even create on our own systems of wellness checks amongst each other in our neighborhood, where we start to develop that infrastructure? And you've seen it a lot with mutual aid situations that people are developing within their communities, where there is this kind of understanding that people need access to water, that people need access to food, and you see people mobilize themselves. So how do we get access to these monies where we're actually working, maybe within these systems, to create an alternative that's shifting thinking, right? We're not going to get it perfect. We're not going to get it right, but we start to shift and get out of the box of where they want us to be, which is in treat COVID, treat COVID, treat COVID. And we can start saying, well, we're going to treat everything. We're going to start looking at the home. We're going to start looking at the schooling. We're going to start looking at, are there other needs? Is there, addiction that we're dealing with as well? Even if is it the family that we're looking at, not just the patient, not just the person who's impacted by COVID? And these conversations that I've been fortunate enough to be in spaces makes me realize, like, it's not a solution we're going to come to immediately, but it's how we start to grab hold of these institutions, of this funding, and shift the thinking, so that as we start to shift our own thinking, we start to decolonize the way that we're engaging, right? And having these opportunities, which I'm now going to soon have opportunities to go into homes. How are we taking advantage of being in a home and being able to have conversations outside of the scope? As a nurse, you'll hear multiple times that nurses engage with their patients on levels beyond what we're there for and beyond what we have time for, but do it because we know we have to treat those other situations in order to even treat the immediate situation. So whatever the food situation is, there's multiple times where even to be able to help treat a patient within the hospital, you find yourself going downstairs, using your own money to buy food, using your own money to buy different things, because you're trying to think outside of the box of, I just need to hang my antibiotics, I just need to put an IV in, but you're actually trying to work outside of it because you know you have to treat the family member that comes in, you know you have to treat. So what kind of opportunities
Absolutely.
that in are we expanding and decolonizing what our task is, what we're being told to do, but how can we decolonize that and open up that landscape as well?
And then there's a message from Nadia as well, that yes, I can see the state using teachers as contact tracers. I can definitely see that become some mandatory type reporting type of thing. Teacher self-defense and defense of students and families must be a part of our thinking when we think of schools, to push back against the historical narratives and realities, as well as the current state of schools being spaces of criminalization, cultural genocide, and violence. Thank you, Nadia. And then James put in this the new message as well. COVID in the prison COVID in the prison kill boxes has raised some fundamental notions about the nature of incarceration and the state's insistence on not letting criminals out of prison. This inhuman torture in cages enhances the logic of abolition. Absolutely, thank you. So folks, the last few minutes that I have.
One more comment.
I'm sorry?
There's one more comment in the chat.
There is one more. Oh yeah, yes. So that's from Virginia. That I'm thinking of ACT UP and TAG, which is treatment against groups, work to intervene and research treatment and protection of community health during the AIDS pandemic. Not perfect work by any stretch of imagination, but some useful parallels. So absolutely, I mean, there's a whole lot for us to learn, and as our late comrade and brother Eddie H. used to remind us that, you know, the first step is to decolonize ourselves. The first step is to really, really shed that baggage and do a whole lot of unlearning that needs to happen on our path to liberation and abolition. Shakir, you've been very nicely quiet as a co-host. Any comments that you would like to make up until now, that what you have heard? And I know you've been going into the jails. So you want to talk about that a little bit, like, you know, just what is happening? I know just a couple of days ago you were in a prison as well. We've been working with prisoners' liberation.
Yeah, no, thank you. Yeah, so I've, as Ahmed mentioned, yeah, I've been going into LA County jails and talking to people inside. And, you know, it's like every kind of story you hear is just totally kind of devastating. And the one, you know, the thing, even now to this day, they talk about how inmates are being quarantined, but what's really happening, and that's their language, inmates are being quarantined. What's really happening is that everyone who's incarcerated in the same area is just kept there, being exposed to each other, coughing on each other, unable to do anything. One thing that was announced today that I'd actually love to hear some of our public health folks on is, so the jails they're starting to test, and they're trying to expand testing inside. And there's some possibility, I think, of universal testing within the jails, similar to what's happening in a lot of other, like in nursing homes and those kinds of facilities. And so just, you know, what are some ways to both think about that move of testing everybody and testing people in a space where they don't have any other choice, but they also just have no other way of knowing or seeking testing themselves. And then also, when that information comes out, what are ways for the people who are tested, the people inside, to how can they mobilize based on that? What are ways for them to organize based on that knowledge of, you know, who's positive and who's not? How can that empower them?
I feel like this here falls into one of those, you know, those biomedical traps we were talking about, right? Like testing for what end? And so for me, the concern is that how are they going to reimagine what to do with a place that we've said cannot provide care, right? Outside of a COVID situation, it's not a place where people should be, right? So then given that, then what is testing going to do? And is this one of those things where we had a list of demands, and the ones that were pulled out of it were the ones that were more techno-scientific, and then the reaction is that, well, okay, we must be doing something good because we pulled on technology here, right? And so it's going to fit some sort of purpose. I mean, outside of knowing what kind of care they plan on giving to prisoners, that testing doesn't make any sense unless they're going to say, okay, because now we see everybody here has it, everybody gets to go home. Like, and short of us imagining them doing that, then what role is testing going to play in this kind of context? And also, given how long they've gone without testing, I almost think here the issue of testing is going to mean something for people who are recently being arrested and locked up. And I wonder if this is now a way to think about managing new prison populations versus as really an effective strategy for those who've already been locked up. Yeah, that's my initial, kind of like where my mind is going in terms of thinking questions around that.
Thank you. And I think with the experimentation, of course, like now you have a captive, literally a captive audience. And I'm reminded, just like last year when we found out that how they were tapping into people's the phones in jails and experimenting with people's voices to start developing and have voice recognition systems. And selling that information to high-tech companies so they could develop. So this is where a lot of this information would move as well. I have a comment from Stefan that some of the experiences I've had as a National Lawyers Guild legal observer at protests may have some application here. It is a concept of developing a counter-narrative to the states. Protests, especially in high-density places, are well known to have multiple cameras and surveillance systems built in. The camera feed from a particular corner is likely being sent real time to a fusion center. They control the image, seen and recorded. My objective as a legal observer is to provide broader context with a social justice bias. One could argue both direct observations, mine and the states, are accurate. My biases are community-based with social justice as an emphasis. It is this control of the narrative that helps. Can we produce our own community narrative on COVID separate and as a counter to the states? So I think that's with that, of course, we at 7:56. I think that's our call to action, that how are we producing our counter narrative? And I think this is one of the function of these webinars in this collective conversation and knowledge exchange and building collective power, that how are we building that counter narrative to the state, which is liberatory, which is on our pathway to freedom, and which is also on our journey to abolition as well. And lastly, James has put a comment like, putting on my FIP cap, if I was still locked up, I would want testing, the thought that it would be a to confirm what we said about COVID and get some people out of prison, not foolproof, but. So I guess James is sharing their own experience of being formerly incarcerated, and how are they thinking right now as, like, if a test was to take place, what that could do. So folks, with that, we're gonna wrap up today's webinar. I wanna thank each and every one of you for being on there. Thank you so much, Jamie and Beta and Angela and James and Shakir and everybody else in Virginia. It's so awesome to see you, and everybody else, Nadia, everybody else who made these comments. This is going to be on our website. The recordings of webinars are already have been posted on the website. This is going to be posted as well on the website, hopefully by Thursday. Look for the bulletin to be coming out by Thursday as well. Look for the Medium post on this BS around hotspot policing of COVID by Predpol. That's going to be released tomorrow. I also really want to take a moment to appreciate Jordan J. for giving us some really dope-ass graphic notes as well, which are being uploaded on the website along with the tapes. And next Tuesday, we're going to have Simone Brown, who has done extensive work on the surveillance of Blackness. Their book out of Simone is an academic and also an activist, a scholar, teaches at UT Austin, wrote this book, Dark Matters, on surveillance of Blackness, which has been a seminal work, which has guided and inspired a lot of work of the Stop LAPD Spying Coalition. So we're going to have Simone and Pete White and conversation along with other folks in the community as well. So that's going to be next Tuesday on May 19th at 6 o'clock. So look out for that. Thank you all very much, and this was lovely and much appreciated. And we're hoping and sending good vibes to Dorothy. Hope everything is well with them, and we'll send them our best wishes as well. So be safe and be healthy, and we'll see you next Tuesday. Thank you very much.
Thank you.
Thanks.
Yes.